St. Peter's Healthcare System, St. Peter's University Hospital, and the Children's Hospital at St. Peter's University Hospital by Group C, Keisha, Lauren, Kashif, and Shanker. St. Peter's University Hospital is a non-for-profit 478-bed acute care teaching hospital. It is located in New Brunswick, New Jersey, and began in 1907. It employs over 2,600 healthcare professionals and support personnel and has more than 900 doctors and dentists on staff. Yearly, they treat 30,000 inpatients and have more than 200,000 outpatients. The Children's Hospital at St. Peter's University Hospital is an acute care children's hospital. It has a child life program which helps to educate and prepare children for their stay, and also a pediatric emergency department that can handle any injury or illness for a child. They yearly care for 9,000 inpatients and have over 45,000 outpatients. The pediatric unit specializes in care from newborns to children through young adulthood. They operate one of the largest, most advanced NICUs in the country at a level 3 with 1,300 newborns each year.
St. Peter's Health System has generated a profit of $3.6 million. However, in-depth analysis shows that the core hospital services, such as the hospital proper, the Children's Hospital, and the Physician's Associates practice, all operate at a loss or a significant loss. Overall, the primary expenses stem from salary obligations and supply expenses. However, due to a significant amount of long-term debt, whose obligations start kicking in the next few years, it is likely that hospital expenses are going to increase significantly. Specifically, despite having over $400 million in assets, St. Peter's holds a significant amount of long-term debt, over $100 million, and in pension liabilities, $110 million, which results in a debt ratio of over 90%. This resulted in a subpar credit rating from financial agencies. Finally, per the financial report, this debt was taken on so that St. Peter's could cover their bills due to revenue and cash flow problems. This is a telling sign for the financial future of the hospital. St. Peter's, when compared to the industry average, has less of a reliance on Medicare and Medicaid for patient revenue. This provides a small cushion for St. Peter's from changes in Medicare and Medicaid reimbursements. However, it is worrisome that St. Peter's does have 5 times less in self-pays. Increasing self-pays and commercial insurance is a great way to increase cash and cash equivalents, which will protect them from cash shortages in the future. Additionally, in terms of community outreach, in an attempt to cut down on excess expenses, St. Peter's lowered community benefits from 8.5% to 7.5% this year. However, this is still well below the industry average of 12.4%. Additionally, St. Peter's offers less than half of the industry average in charity care. It is likely that St. Peter's will be forced to lower these percentages in the future if they cannot control their expenses in other areas in the hospital. St. Peter's operating margin is significantly lower than the industry average. This shows that there is a clear lack of expense control at St. Peter's. Due to the hospital's focus on children's services, it is unlikely that specific expense cuts can be made, so cuts have to be made elsewhere in the hospital. The low operating margin also relates to the low return on assets. St. Peter's is almost 4 times below the industry average, which means that they are not utilizing their assets properly for revenue generation. Additionally, the debt to capitalization percentage shows that 2/3 of St. Peter's is financed by debt. This is almost double the industry average and is a major issue that needs to be dealt with in the future. The significant debt taken up by St. Peter's is understandable due to their extreme lack of cash on hand. St. Peter's has almost 20 times less cash on hand when compared to the industry average. Any cost surges will force the hospital to take on more debt. This was already the case with an increase in the credit line to a local bank to $10 million from $5 million.
St. Peter's Hospital is a non-profit hospital, and under the 2010 Affordable Care Act, it must conduct a community health needs assessment. This assessment identifies critical health needs and defects within the community. The first assessment was conducted in 2012, and Robert Wood Johnson Foundation awarded them a grant to help implement the Community Health Implementation Plan. The next assessment was recently completed in 2016, and its main focus was avoidable hospitalization and emergency department visits. The observation was broken down into 4 categories: non-emergent care, such as headaches, where the condition does not require immediate attention; emergent but primary care treatable, such as bronchitis, which requires treatment within 12 hours but can be treated effectively with primary care services. Emergent ED care needed but preventable and avoidable, such as an asthma attack. And emergency care is required but could be treated by ambulatory care services. And finally, the emergent ED care needed, non-preventable nor avoidable, such as a car accident where emergency care is needed and definitely necessary.
The findings from the CHNA key informant interviews were categorized into 4 themes. The first theme discusses the diversity found in hospital service areas, making attention to cultural competence and person-centered care essentials for effective service delivery. Diversity exists among patients in languages, cultural practices, life experiences, literacy levels, and various disabilities that may affect their ability to physically access care or communicate with certain providers. There have been an increase in immigrants from Central America who are fleeing violence, and the safety net provided an increase in Asian clients in the New Brunswick community. Theme number 2 discusses the kind of health conditions that are often of most concern to interviewees. These are chronic, often co-occurring conditions. And findings in this area were just like the first CHNA back in 2012. A variety of chronic health concerns were mentioned in response to general questions about major health problems within the community. These varied and included diseases such as obesity, behavioral health conditions, dental problems, asthma, chronic kidney conditions, and workplace injuries, to name a few. The third theme discusses the gaps and barriers to residents' health that remain to have expanded since the 2012 assessment. Positives include the expansion of health insurance under the ACA and Medicaid expansion, the healthcare resources available at the 2 New Brunswick hospitals, and the robust relationship among stakeholders and service providers in that area. However, system gaps or barriers remain or need to be expanded since the 2012 assessment, leading residents to forego daily preventative care, thus disrupting care continuity, which is needed and very important for a company or a healthcare system's success. The final theme discusses residents for information education about health issues, the healthcare system, nutrition, and navigating the delivery of the healthcare system. A positive note, and similar to the first CHNA report, was that most health and access-based indicators in the hospital's primary service area are still consistently better than the benchmark rates for all healthcare systems in the state of New Jersey. However, disparities for the uninsured and low-income respondents continue and are quite large, and this is seen in all 3 components of this study.
After conducting the 2016 assessment, results shows that the avoidable hospitalization and emergency department visit rates were lower overall compared to the New Jersey benchmark averages. This suggests adequate access to healthcare resources and primary care services. Findings also indicate that the percentage of avoidable hospitalization was higher for Medicare and self-pay or uninsured patients when compared to the New Jersey rates. This supports that the elderly are more likely to be hospitalized due to chronic illnesses, but also shows that uninsured patients and self-pay patients wait until their symptoms are very bad before seeking medical attention. However, findings shows that the Medicaid and self-pay patients or uninsured patients' avoidable emergency department visits were higher than the New Jersey rates. This suggests self-pay patients and uninsured patients encounter barriers to primary care services, and it shows that having no insurance, these patients may also have no primary care physician, and therefore going to the emergency department is their only option of seeking care. The assessment finding shows that chronic illnesses are the leading conditions associated with avoidable hospitalization, such illnesses as chronic obstructive pulmonary diseases and the congested heart failure. When compared to the New Jersey rate, COPD overall average is the same as the New Jersey rate. However, the congested heart failure average was lower than the New Jersey rate. Now taking a look at the pairs distribution. We know that This plays a huge role towards hospital finances. And in the case for avoidable hospitalization, the dominant payer in this scenario was Medicare, followed by private insurance. However, in regards to the avoidable emergency department visit, the dominant player was private insurance.
A few innovative recommendations and methods to avoid hospitalizations and ED visits could be increased charity care. That would just be the local community having discounted rates when they come and visit St. Peter's University Hospital. Now, that is something completely different from Medicare and Medicaid. We can also lower the numbers of beds in the emergency department. That would result in more focused look on triage care or an express lane, which would encompass seeing patients that have more profound sicknesses first and or having nurses do discharges and or seeing patients. An example of this would be having a nurse give a flu shot and or some sort of medication to a patient that is in the emergency department. We can also direct patients to utilize outpatient services. Now, hospitals nowadays are utilizing outpatient services to lower costs in the emergency department. These would encompass patients that do not have sicknesses that would require them to stay overnight or in the hospital for observation for alleviated amount of time. We can also promote primary care services to the new ED patients. That would just implement a discharge follow-up service, which would make the patients in turn see their PCPs rather than go into the emergency department, lowering costs and having miscommunication and all this.